buzz in 1 hour. Let's do it.
So what is the presentation time?
6 minutes each talk.
6 minutes. Yes.
Saurabh, good evening. Welcome.
We are live.
Hi, sir. Hi.
We are live.
Okay. So good evening, friend, and welcome to the 5th webinar of our Team ARC in this tenure of 23-26. Team ARC is privileged and welcomes our President and the GC of All India Ophthalmological Society. Today, we are fortunate to have our President, Dr. Harbansh Lal, sir, who will be joining us shortly, and Dr. Samar Basak for this particular webinar as a chairperson. We also have Dr. Guru Prasad, sir, Dr. Saurabh Pratwardhan, Dr. Pradeep Mohanta, and Dr. Kiranjit, sir, who are the ACE surgeons and who are the pioneers in various techniques of rehabilitation of aphakia. They will be the expert panel today, and they will be making special comments after the presentation of these young Turks. Welcome all of you, sir.
Thank you.
ARCIS will be hosting such niche webinars on various subspecialties on every third Friday of the month from 7 to 9 p.m. And we are planning it in a slightly different way. This time, the onus was with Dr. Srinivas Joshi, who is a member ARC South, and who has decided to create this particular webinar, that is the IOL Jawans, where even if there is a lost bag, we do not lose hope. And we are lucky to have young vitreoretinal surgeons, young Turks, who are going to present their cases in a different styles. So I welcome them all. Now I request Dr. Srinivas Joshi to carry forward the further moderation.
Thank you, Prashant sir, for that introduction, for the kind introduction. Once again, I welcome all the expert panel, all the young Turks who are here. So I think the concept here is because the IOL lost bag but not lost hope. The secondary IOLs are being performed not only by vitreoretinal surgeons but also by anterior segment surgeons as well. I think it's now become the next after the cataract, which is said as the bread and butter, and how we have to push that bread and butter more fruitful is we need to have our own cover. So because of which there is a mix of both anterior and posterior segment surgeons, young surgeons we have here today, who will be explaining the different techniques of whatever they are performing and whichever they have excelled in their performances and given good results to their own patients. So today let's have a sortium of various techniques which are to be discussed in the secondary IOL today. So for the first speaker, I think we will have Dr. Shilpi. Is there, sir?
No, Shilpi is not with us.
Okay, so we'll have that presentation a little later. So first we will go with the glued IOLs. We have Dr. Nagesh CN from Narayan Netralaya, Bangalore. Dr. Nagesh, a very young vitreoretinal surgeon. I have seen him presenting in various platforms. So he is now doing various scleral fixation IOLs along with the glue and not with the glue. So he'll be telling us, discussing us what are the advantages and disadvantages of the glue technique. Is it really necessary, or we have any other things in the buzz? So I now request Dr. Nagesh to please go ahead with his presentation for 6 minutes, followed by the expert panel. We have Dr. Guru Prasad sir here. We have Dr. Kiranjit here. We have Dr. Saurabh Patwardhan here. So they'll be throwing their comments about how best we can handle these cases. So over to Dr. Nagesh, please.
Thank you so much. Thank you, AOCRC, for the opportunity, and thank you, Srinivas Joshi, sir. Shall I share my screen?
Please, Nagesh.
My screen is visible.
Dr. Prashant, can you please send the link to Apurva again?
Okay.
Sir, it is there in the group. The link is being shared in the IOL Jawans group, WhatsApp group.
I will send her again. I'm sending.
You can see my full screen.
Yes.
And am I audible?
Yes, Dr. Nagesh.
So great. Thank you so much. And thanks AOCRC committee and then Srinivas Joshi, sir, for having me here in this webinar. So I'll be talking about the glued IOLs. Now, first, whatever the sutureless scalar fixation of the IOLs we do, there are a lot of modifications, innovations, and inventions. There are basically fundamentally two things that we need to keep in mind. One is the techniques of haptic exteriorization, like how you exteriorize the haptics, starting from the scleral cornea tunnel to the cornea, into the AC, under the iris, and then bringing out the haptics at 3 and 9 o'clock position. So there are various techniques and modifications. I'll show you a couple of videos how you can do it off. That's very, very non-specific. And the specific thing is how you second part of the surgery is how you secure those haptics into the sclera. This is very specific for each technique, whether you are doing a Gabbard-Sherrod technique or whether you're doing a Agarwal technique or whether you're doing a Yamana technique. So I'll just go and I'll divide the surgery into two parts, which is a non-specific part and the specific part. The way this glued IOL technique comes with, the glued IOL technique comes with the way how you secure the haptics into the sclera. So now, so the first is how you exteriorize the haptics. So look at this, the pictorial diagram where you can pass a 26 gauge needle through the scleral flap at 3 and 9 o'clock position, bring it through the AC under the scleral cornea tunnel, and in this 26 gauge bore needle, you can dock the haptics of the IOL. Either you want to dock it a PMMA rigid lens or you want to dock a soft lenses with a 3-piece lenses. You can dock it and then bring it out through the AC under the iris into the 3 and 9 o'clock position. So I'll just show you the small video. So this is how you can dock it, where the docking is done extraocularly. This can be done only for rigid lenses. If you want to put a 3-piece rigid lenses, you have to make a large corneal section and you can dock it extraocularly. This is quite easy, and then for the beginners, this is a very easy technique how you can dock it and then bring it out at 3 and 9 o'clock position. So when you are docking the trailing haptics, make sure you are holding the leading haptics, otherwise it will slip down into the vitreous cavity. This is a quite simple technique how you can do it. Even the beginners, it will be very easy for them to do it. The second technique is kind of a part of the Yamana technique where you can dock the haptics into the 26 or 30 gauge bore needles inside the antechamber at the level of iris plane. So I'll just show you, either you can dock it simultaneously or you can dock it sequentially. So here we have, it's the IOL is there on the iris plane. Now you position the IOL and then take a 26 gauge needle at 3 and 9 o'clock position. With the IOL holding forceps, you just dock it into the haptics, you dock it into the 26 gauge and keep the 26 gauge there itself, and then dock the other end, and then both the ends simultaneously you bring it out. So this is a part of the Yamana technique how you can dock it and then bring it out outside. So if you're not comfortable doing it simultaneously, you can do one by one. So the next video, it shows how you can dock one by one. So in this technique, just a minute. Oh, sorry. Yeah. So in this technique, where what I'm doing, I'm attaching a silicone tire to the 26 gauge needle that will act like a stopper. So I'm just gliding the silicone tire tuber to the haptics so that the haptics will remain there. It won't be slip when you are manipulating the trailing haptics. So once you are done the leading haptics docking and the exteriorizing, you can do the trailing haptics docking and exteriorization. So this silicone stoppers are very, very helpful, and you don't need any assistant to hold it when you are manipulating the trailing haptics. This way you can do sequential docking and then exteriorization of the haptics. And last one is you can do this technique not with the docking, but with the simple forceps. So here I'm just injecting the IOL. So when you're injecting IOL, hold the haptics, tip of the haptics, and then bring it out on this end. And the trailing haptics, again, you can bend it, and then with the handshake technique, you can bring it out at other end. So these are the different ways how you can bring out the haptics and exterior at 3 and 9 o'clock position. This is the first part of the surgery. The surgeons, which are comfortable, they can use any kind of techniques to bring it out. Now, what's special with the glue technique now here? In the glue technique, basically once you haptics are bring it out, so we are bringing out the haptics at 3 and 9 o'clock or 6 and 12 o'clock position under the scleral bed. So we are making a 3 and 9 o'clock partial scleral beds. Under the bed, you are bringing out, and again you are making a one more tunnel, that is Gabba-Sherrod tunnel, and so that the maximum length of the haptics will be under this within the sclera. So that means to say the area of contact of the haptics into the sclera is so large that the stability, it gives a lot of stability, and then the foot centration. This is the uniqueness of the glued IOLs over here. So I will show you, this is the last video, I'll just show you. Yeah, just a minute. Yeah, this is the last video. So this is a case I just operated yesterday. I was just capturing. This was a Coloboma one-eyed patient who had a very black cataract. In fact, our anti-segment surgeon was hesitant to do surgery because there was a grout phacodonosis. And that's the reason we thought, okay, we'll take it up from our side. And then the plan was to do a lensectomy, vitrectomy, along with the glue IOLs. So we try to do a simple limited congenital peritoneum at 3 and 9 o'clock position. The plan is to do a scleral flaps at 3 and 9 o'clock in this. And the white-to-white diameter was 12. So I had no issue with the IOL selections. So usually you can do a 2 into 2 millimeters, the flaps on either side. Either you can use a crescent or you can use a hockey stick knife, whichever the thing you are comfortable, you can use it. Even the markers also, you can use a PK markers or you can use a simple markers. The only thing is they both should be diagonally opposite, preferably at 3 and 6 o'clock position. That gives a good centration. So this is how you can rise the flaps, quite simple and quite easier to do this. So the flap should be raised at the 3 and 9 o'clock position, and make sure that it is not too deep and there should not be any button holding over there. So once the flaps are raised, so I'll just skip the vitrectomy lensectomy part. So basically, I did a lensectomy with a phlegmotome, and then this was the coloboma side. The nucleus was down, so I used the phlegmotome, and I'm just skipping these things. It is not for the discussion part. So coming back to the procedure again, so I'm just marking 1 millimeter from the limbus. The 23 gauge needle, you just go perpendicular to the sclera and then parallel. So this is how I make a ports under the sclera. And this is a section for my injector. So 2.8 millimeters injector B, I use it. So this is how I hold the tip of the haptics, and slowly you inject and bring it out. Once the injection is complete, bring it out. So sometimes it may flip out like this. There's nothing to worry about. You can just flip it again. So once this is done, now with the handshake technique, again you insert the haptics inside. With the handshake technique, you go from the other end of the scleral bed, hold it at the tip and bring it out. So this is how you can do, or this procedure can be done in any other ways. This I have showed you before. You can use extraocular, docking or MNA technique and all those things. Once it is done, so we are just doing again GABA shaded tunnels at the bed of the scleral bed. So once it is done, you can just insert the haptics of sufficient length and just make sure the centration is good while you're inserting it. So the length of haptics to be inserted depending upon how it is well centered in the period. So this is how it's well centered. So now once it is done, so now you can apply a glue under the bed once, and then again you can apply the glue for the conjunctiva as well. So in this way, it gives a double protection where GABA Sherrod tunnel will give a mechanical support, and then the glue will give an adhesive support for this thing. So that's the best advantage with the glue IOLs, where the stability of the IOL haptics are very, very good, and the area of contact of the IOL is the largest compared to any other IOLs. So that's the reason I prefer this technique for extremely difficult cases like these coloboma cases, or if you want to do for large corneas like a Marfan syndrome and all. I think this is the best way to do it because the slippage is very, very less in this kind of cases. That's it for the day. Thank you so much.
Thank you. Thank you so much, Dr. Nagesh. I think beautiful videos. You have shown various techniques here. So my first question to Dr. Guru Prasad, sir.
Yeah, before Srinivas, can I interrupt?
Yeah, please.
Sir is here. Just we would like to introduce and invite President Dr. Harbansh Lal sir who has joined our webinar. Sir, so in spite of his busy schedule, he has joined us. Sir, just a few comments. Today we are having a webinar on all the wherever aphakic cases, wherever we are lost, and we are having all the young Turks and senior people like you as faculties who will be giving expert comments on their presentation. So you can see the pride of our country.
I think this is, Prashant, this is a really excellent webinar. The topics are really very good because there are so many ways to do the secondary IOL. And this is virtually covering every aspect of it. It's really great. And it will be great learning. I think you and your team are doing a wonderful job. And I hope you will keep on doing that. Thank you very much. And I'm enjoying and listening to it.
Thank you, sir. Thank you. Srinivas, please. Sorry for that.
Thank you, Harban, sir, for those encouraging and supportive comments. Thank you very much, sir. I hope you will be there throughout our webinar, and we are trying to make it as short as possible. That's why we have kept it only 6 minutes per talk. It's just to showcase what all techniques we can just do that. So, Guru Prasad sir, I think Nagesh showed excellent videos. My first question is, do we really have to use that sponge? It's a wonderful idea, Dr. Nagesh. So, is that we have to bring both the haptics simultaneously out together, or we can just try to cauterize one haptic and try to move with the other haptic, or bringing out both together and try to cauterize it is much better, was my first question. Second thing is, he has taken 1 mm. So we have learnt it as 1.5 mm. So I have seen surgeons taking even 2 mm. So what is the sweet spot? So whether we should use 1 mm, 1.5 and 2, in which conditions does it really vary?
The first question, whether we need to dock it simultaneously and then bring it out, it's absolutely a surgeon's preference.
Yeah.
There is no
No,
hard
I'm
and
asking
fast
what
rule
are
for
the
that.
advantages and disadvantages? We just want to discuss it, Dr. Nagesh.
Yes, see, when I want to do a docking simultaneously, I'll be using a 26 gauge needle. So when you want to bring a 26 gauge needle, and the docking of the trailing haptics or the second haptics will be very easy when the 26 gauge needle is already there inside. That means the rotation of the IOL will be very, very comfortable to dock the second one. If you bring the one haptics outside, now the trailing haptics will have a different rotation direction compared to your docking of the second thread. That's the problem with the sequential docking system. So that's how the MRE, in fact, even as is told, the docking will be very, very easy because the direction of the haptics will be same as if you were 26 gauge, and it will be so easy for you to dock it if it is there inside. That's the thing. And the silicon stopper is something, it works very well because it will prevent the assistant from damaging the haptic strip when he is holding. And this is very simple ENSA class band what we use for retinal surgeries. A small piece of ENSA class band, you cut it and keep it in pieces and then autoclave it, and it works very, very well. Even whatever the manipulation you do, it never slips. That much honesty it has. The
Dr.
third question,
Nagesh, I think we have really taken your points really well.
Yes,
We
sir.
want the expert panel to just throw light on this. Guru Prasad sir.
So let me answer these questions in the reverse order. First, let me address the distance from the limbus that we actually want to enter or exit the loop. So it has been well documented and also proven by UBM and other techniques that the ciliary sulcus is 1.5 millimeters in an average eye. It can be 2 millimeters in a longer eye, but in an average eye, which is about 23 millimeters in length, I think it is 1.5, and 1.5 should be ideal, although 2 is not a mistake. If you do it at 2 millimeters, it doesn't amount to a mistake. So that is question number 3, which I answered. Question number 2, I think, question number 1 I'll come to. That is bringing both the haptics simultaneously. As a vitreoretinal surgeon, I am always worried about what is happening to the vitreous base area, what is happening behind the iris when we sort of manipulate the lens and the loops in an unseen area, which is behind the iris. So we don't know what is actually happening to the vitreous base area. So I preferably feel that ideally we should bring both the haptics out together, which is possible either by the M&A technique or by the technique that I follow, the 4-flange technique, where I bring both the loops out, not actually externalization. I bring threads, the sutures out, where the lens does not wobble within the anterior vitreous. So I think that is a very important point to consider, because we might end up with vitreous base avulsion problems and all those vitreous base related iatrogenic problems in future, which we can obviate by bringing both the loops out simultaneously. But it is easier said than done. We have to, in the practical situations, we have to bring out one loop at a time, all the time taking care that the lens is not out of view. The loops are not going, here and there, and the lens also, the optic of the lens also is not rubbing against the ciliary body. There was one more question which I...
See, the most important point is Yamane described it using a 30 gauge. So it's a very small entry. Now we are using the 26 gauge here entry, and then we are trying to make a flange. So I have seen in one of my case where I tried to pull it out, and while trying to manipulate the other one, this went down because this technique has been described with 30 gauge. So how large the bulb we should make it? Because there are chances that it might slip through even through the 26 gauge wound needle, even though we have done 2 planar wound needle, but there are chances that it might go back. So ideally it has been described for 30. Any lights on this with the other expert panel, Guru sir?
smaller the better. You're right, 30 gauge is definitely better than 26, but the loops that we deal with are difficult to thread into or railroad into the needles. The loops that we normally use, the foldable lenses or the rigid lenses for that matter, are difficult to thread into very small gauge needles at a 30 gauge, and 27 or 26 would be the ideal ones for easy threading and bringing it out, externalizing them out of this eye. So, yeah.
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 Srinivas,
Yes, sir.
regarding the size of the flange, so what Dr. Yamane has used is a thin walled 30 gauge needle. So the size of the needle, including the wall, is much smaller. So what we use generally, what is available is the regular 27 gauge needle, which has thicker walls. So you have to actually see the diameter of the 27 gauge or 26 gauge needle wall, including the wall size, and then the haptic size. So what I have seen is that 27 gauge needle, the size of the entire needle is double the size of the haptic that we generally use. So I make a rule that it has to be just double the size of the haptic, that flange. It should not be larger than that. So that is not needed, because once it is of that size, it is very difficult to, drag it inside the sclera. It will get, stuck in the inside the sclera. It will not go inside. So you have to actually see, because all of us use different size needles and different IOLs also, and each haptic will be having different diameters. So we have to stick to one particular make of IOL and one particular size of the needle, and find out the exact calculation how much size of the flange should be.
I have one question. Nagesh showed one case of a coloboma with cataract nigra partially subluxated, and he preferred to do it through a posterior route. Today, we are having in an expert panel both the anterior segment as well as the vitreoretinal surgeons who would like to take it through anterior and who would feel more comfortable and safer to do it through a posterior segment. Why don't we have comment from Kiranjit and Dr. Harbansh sir over?
I am doing the anterior approach, and I have done quite a few of cases of coloboma with black cataract, even with phacodenesis also. And I usually make a very big long over-rexes, which helps me to sculpt longer and deeper. And then I may use 5 iris hooks instead of 4. Sometimes you have a very small eye, and you want some area, working area in the 6 o'clock area also. So I make use of 5 iris hooks, and then when I am able to make long gutters, they are it is very easy to break them. And if everything goes right, then I put the lens in the bag. Otherwise, I have a iris claw lens to as a backup system. So I'll prefer going through the anterior approach.
Harbansh Lal sir.
So I think definitely, because really, if I want to do, I can do only from the anterior route. So I think anterior route is a good option, and I don't mind even doing extra capsular cataract resection in these cases. I mean, I feel phaco is possible, and particularly patient has got both the eyes, this type of cataract. I don't want the patient to have keratitis and then keep on waiting for a week or two to have the vision getting cleared up. So the first eye, if I get a black cataract in both the eyes of the patient, I usually do ECC, because I'm not even trained for SICS. So I definitely do the anterior route without any hesitation.
What is your
And then
favorite
even if I
choice
start a
of
phaco, and if I find it is taking a little too long, I'm not able to crack it, so I'll convert to ECC, because in any case, phaco incision is on the temporal side. So I come on to the 12 o'clock position and do a safe ECC instead of struggling through the phaco.
So what is your choice of the favorite secondary IOL technique? There are so many sutureless, Gore-Tex, everything is available now. So what is your favorite technique?
So I think if the patient can afford, then include IOL. Otherwise, I do the scleral fixated. And now recently, my daughter has started doing iris fixated, and I really find the ease of doing it really very comfortable actually. Because if suppose something goes wrong on the table, probably iris fixated is a very quick option as compared to any other option. So
Great.
that way, I think
I think
then
we
I've
have
not been any problem. But my personal choice is, of course, glued IOL and SFIOL.
I think we have some supporters to Dr. Vaibhav and Dr. Tanvi, who is going to speak more about the iris clip lenses today. Thank you, sir. Thank you very much. I think we'll go on to the
Yes,
next presentation.
Just one point, Srinivas,
Yes, sir.
just
Yes,
because
sir.
I think Dr. Nagesh mentioned it during his presentation, which is a very important point. What is the corneal diameter of that particular eye of iris coloboma? Because if it is smaller, say less than 8 millimeter, you have to be very careful because the nucleus size is going to be very big. And if we try to do SICS or ECC, you might get stuck in those cases. So in those cases, either phaco, as Dr. Kiranjit sir said, or doing a posterior approach will be a better approach for smaller corneal size. Also, doing phaco, the corneal size is small, so endothelial count overall is less. So you may end up having more corneal edema. So
I'll disagree with you entirely because I operated very small cornea with ACC, even 8 millimeter, 7 millimeter, because now you can make a very good scleral incision. Just go at the periphery. So the lens really comes out very nicely, even in microcornea, where the chamber is also shallow and the cornea is small, phaco is difficult. And because these eyes are already disturbed eyes, even a younger patient of 40 years may have a very hard cataract in these patients, and they don't crack. Not only the color, but they are so leathery, even if they look small. Actually, the nucleus size is usually very big in these cases. So I've done few cases, very small cornea, and actually ECC is very, very comfortable in these patients. Well, you can make absolutely, the incision could be scleral and just entering at the top of the iris.
I think last comment from Dr. Pradeep Mahanta, who is also into the rural area, he might be seeing such a lot of cases. He has some videos. Pradeep, your take on it.
Sir, you're muted.
You're muted, sir.
Prashant, can you please repeat the question?
I think, Prashant, you will have to watch the clock. I think you're...
Yeah. This
No,
last,
Prashant, sir, I think we'll take his opinion for
already
the
one
next,
topic,
next
26
talk we
minutes
can.
already taken.
Yeah, next talk we'll go with his comments.
Okay, fine.
Yeah. Yes, sir. So now we have our next presenter, Dr. Parth Rana, who has discovered his own IOL that is called as the Rana's Tuck IOL. Am I right, Dr. Parth? Yeah, so he has
It's
his own.
Rana and Shaskar Takayal. Yes.
Yeah, so I
So-
think it would be really nice being a youngster. He has already patented it, or in the I think on the way of getting it patented. So we
It's
request
done, sir.
Dr. Parth, a very dynamic surgeon from Gujarat, to just present his technique, Skill Tuck IOL, my innovation technique. Over to Parth.
First of all, thank you everyone, and thank you, sir, Srinivas sir and Bhavan sir, for inviting me here. And I was listening to so much of discussion about this scleral fixated IOL, and that's why I have devised this lens. So all the problems what we are facing in usual conventional IOLs, that won't be there. So either it's a 30 gauge or 26 gauge entry, there won't be any of the issue. Or either we need to fix on iris or something, like we can do the same surgery within 10 to 15 minutes. So that's how I have devised this IOL. I'll just start the video of this. Yes. So
Yes, go
is
ahead,
it
Dr.
visible?
Parth. Yes. Please go ahead.
Whatsoever. Just think of a capsular complication in cataract surgery, where you have already taken a lot longer than usual, and now you have to place the tedious and time-consuming scleral fixated IOL. It is a nightmare, right? Not anymore. Presenting the revolutionary patented design and uncomplicated effortless technique of the Rana and Shah's self-sustaining Scleral Tuck IOL. Scleral Tuck IOL is designed to simplify the complex surgery of scleral fixated IOL and reduce the cost significantly. This design of next generation of scleral fixated intraocular lens is inspired from the price tag label on clothes. Scleral Tuck IOL is made up of 4 different parts: flipper, neck, haptics, and optic. Implantation of Scleral Tuck IOL. Placing of the Scleral Tuck IOL is an effortless technique. inject the IOL in anterior chamber with injector and